I mean, imagine taking, like, just one single hormone pill, one standard 1 milligram tablet.
Okay.
But instead of swallowing it, you figure out a way to make that one pill last for an entire year.
Right, yeah.
So no daily doses,
Mm.
no massive spikes and crashes in your bloodstream.
Mm.
Just that one pill's worth of medicine stretched out perfectly over 365 days.
It sounds like science fiction, honestly, but it's a very real, incredibly precise piece of medical engineering. And it represents this massive shift in how we think about treating the human body.
Yeah.
You know, moving away from just saturating the entire system and moving toward highly targeted, localized therapies.
Exactly. And today on this deep dive, we're looking at how that specific localized approach is completely revolutionizing the treatment of genitourinary syndrome of menopause, or GSM.
Yes, which is such an important topic.
It really is. And we're looking specifically at localized estrogen therapy, and even more specifically, the 90-day estradiol vaginal ring, the one known commercially as A-string.
Which is just an utterly fascinating device to break down, both in terms of its pharmacokinetics, like how the body actually processes it, and the clinical strategies around its use.
Right. And while we will absolutely get into the physics and the biology of how this works, our primary mission today is to answer a highly specific but incredibly common clinical question.
The troubleshooting question.
Exactly. A question that a lot of you listening might be facing right now, which is, what are the specific medical guidelines for adjusting your treatment if you're using this 90-day ring, but your baseline dryness and discomfort persists?
Because, as we're going to see, the rules for adjusting a continuous 90-day device are completely different than the rules for, like, adjusting a cream or a pill.
Totally different. Okay, let's unpack this.
Well, to really understand how to troubleshoot the treatment, we first have to understand the microscopic mechanics of the problem itself.
Right, the baseline.
Yeah. We assume most of you know the basics of menopause, you know, the overall drop in systemic estrogen. But what's happening at the tissue level in the pelvis is this really specific cascade of events.
Okay, walk us through it.
So estrogen is essentially a signaling molecule. For the vaginal and vulvar tissues, it's the signal that tells the epithelial cells, the lining of the tissue, to constantly multiply, plump up, and renew themselves.
It's like the engine for cellular turnover.
Precisely. And as those healthy, plump cells mature and eventually sleep off, they release something called glycogen.
Which is a sugar, right?
Yep, a stored form of sugar. And this is where the local microbiome comes in. You have these healthy bacteria in the vagina called lactobacilli.
Yep.
And they basically feed on that glycogen. As they digest it, they produce lactic acid, which is what keeps the vaginal environment highly acidic, usually at a pH below 5.
Which is an inherently hostile environment for bad bacteria, right? So it's basically the body's natural defense mechanism against infections.
Exactly. So
Yeah.
look at what happens when estrogen drops during menopause. That signal for cell turnover just stops.
Wow.
Yeah, the tissue begins to thin out and shrink. And this is what we mean when the sources use the term atrophic vagina. It's literal atrophy. And because cell turnover halts, there's no more glycogen being released, so the lactobacilli literally starve to death.
Oh, wow. And without the lactobacilli producing the lactic acid, the pH level rises.
Exactly. It becomes less acidic,
Right.
and the tissue becomes dry, incredibly fragile, and prone to severe inflammation. I mean, this is the reality of GSM. It isn't just a minor inconvenience.
Yeah, not at all.
For many, it means walking feels like sandpaper. Sitting down causes stinging. Sex becomes excruciating. And because that acidic defense shield is gone, bad bacteria easily colonize the urethra.
Leading to a heavily increased risk of recurrent urinary tract infections.
Yes.
So historically, the fix was to just put the patient on whole-body hormone replacement therapy, systemic HRT, which is brilliant if you're dealing with severe hot flashes or brain fog or bone density loss. But if your severe symptoms are strictly localized to your pelvic floor, treating it with a systemic pill or patch is kind of overkill.
Oh, absolutely.
It's like turning on the massive sprinkler system for your entire property just to water one single dying potted plant on your porch.
I love that analogy. And often that massive sprinkler system doesn't even hit the potted plant effectively.
Wait, really?
Yeah, the clinical guidelines highlight that at least 20 to 25% of women who are already on systemic HRT still experience these local vaginal symptoms.
Wow, a quarter of them.
Yeah, because the blood circulation to that atrophied tissue is so poor that the systemic dose just doesn't penetrate enough to rehabilitate the area.
So enter the S-string. This is the shift from the whole yard sprinkler to a highly targeted, slow-drip irrigation line planted directly into the soil of that one thirsty plant.
Exactly.
Physically, we're talking about a soft, slightly opaque, flexible silicone ring. It's about 55 millimeters in diameter.
Right.
And hidden inside the core of this silicone is a drug reservoir containing 2 milligrams of estradiol.
And that estradiol is bioidentical. It's chemically indistinguishable from the estrogen the human body produces naturally.
Okay.
But the key here isn't just the drug, it's the delivery system. The
Yeah.
ring does not dissolve.
Right.
Instead, it releases a highly controlled, ultra-low dose of 7.5 micrograms of estradiol every 24 hours. The patient inserts it high into the upper third of the vaginal vault, and it stays there continuously for 90 days.
Which brings us back to that mind-blowing statistic from the British Society of Sexual Medicine guidelines. That 7.5 microgram daily dose is so microscopic that the total amount of estrogen your body absorbs over an entire year of wearing these rings is roughly equivalent to taking just one standard 1 milligram oral estradiol tablet.
It perfectly illustrates the power of local delivery, you know?
Right.
By putting the hormone directly on the target tissue, it goes straight to work rebuilding the local environment. It thickens the epithelium, brings back the glycogen, feeds the lactobacilli, drops the pH, and restores the barrier.
All with minimal absorption into the systemic bloodstream.
Exactly.
Okay, but let's dig into that minimal absorption claim for a second.
there.
Because if you're putting a ring full of active hormones into a tissue that has been starved of estrogen for years, a tissue that is incredibly thin where the blood vessels are sitting right at the surface, what actually happens on day one? Like, how does the body process that initial insertion?
That is a crucial question. The pharmacokinetics here are fascinating. When you first insert the ring into an untreated atrophic vagina, the drug crosses that thin, compromised lining very easily and enters the bloodstream.
Okay.
So there is an initial peak in systemic absorption. Within about 3 hours of insertion, the blood plasma levels of estradiol peak at around 55 picograms per milliliter.
Wait, 55 picograms per milliliter. That's actually approaching the systemic levels of someone using a standard transdermal HRT patch, isn't it?
It is, briefly.
Oh, briefly.
Yeah, that spike is incredibly transient. Within 4 hours, those blood levels begin to drop rapidly. And by days 2 or 3, the plasma levels stabilize at a very steady, low state of about 10 picograms per milliliter or less.
Okay.
Which is well within the normal postmenopausal range and completely distinct from the 40 to 70 picograms per milliliter that systemic transdermal therapies maintain.
And this leads to a detail in the data that I found absolutely brilliant. The sources show what happens when you take that first ring out after 90 days and insert the second one. The initial absorption spike on that second ring is roughly 38% lower than the first one.
Exactly. And why do you think that is?
Well, because the tissue has physically transformed, right? It's no longer thin and fragile.
Yeah.
The guidelines mention the tissue becomes cornified, which, to be clear, doesn't mean it turns into corn.
No.
It means it becomes keratinized, right? It builds a tough, protective outer cellular layer, almost like a microscopic callus on a mucous membrane.
That is a perfect analogy. The vaginal epithelium has thickened, it's rebuilt its structural integrity, and it's cornified. Because it has restored its own physical barrier, it literally absorbs less of the hormone into the systemic bloodstream.
So the tissue is healthier, so it holds the estrogen locally where it belongs.
Yes. This tissue restoration process takes about 2 to 3 weeks before the patient feels the full therapeutic effect. Interestingly, one of the earliest signs that the tissue is waking up is an increase in normal vaginal secretions, which, mimics the natural fluid production experienced prior to menopause.
Now, I have to push back a little on the physics of this continuous 90-day release.
Okay, go for it.
Because if you have this initial surge of the drug leaving the ring on day one, and then it drops off within hours, how does the ring know to keep releasing exactly 7.5 micrograms for the next 89 days? Like, why doesn't the physical reservoir just dump everything quickly or run out of juice prematurely?
This is where we get into the brilliant engineering of the silicone matrix itself. What's fascinating here is that the ring operates on a core principle of physics known as Fick's law of diffusion.
Okay, Fick's law. Let me see if I can picture this. Diffusion is basically just molecules trying to spread out evenly, right?
Right.
So if I drop a tea bag into a mug of hot water, the concentrated tea compounds in the bag naturally diffuse out into the clear water. But they don't just keep diffusing forever. Eventually, the water becomes so saturated with tea that the process naturally pauses. It reaches equilibrium.
Exactly right. Fick's law dictates that molecules will naturally move from an area of high concentration, so the tea bag, or in our case, the core of the S-string, to an area of low concentration, which is the vaginal tissue.
Okay.
And they move until the two areas reach an equilibrium.
So if I were to somehow take a sip of that tea and then replace it with fresh, clear hot water, the tea bag would automatically start releasing more compounds to balance out the new water.
Yes. The S-ring is essentially a self-regulating system. The ring maintains a constant, localized target concentration. As the vaginal tissue actively uses up the estradiol to build new cells, the local concentration in the tissue drops.
Oh, I see.
And that drop in concentration automatically triggers the silicone ring to release a tiny bit more estradiol to maintain that perfect equilibrium.
Wow.
It's this continuous physical feedback loop that ensures perfectly stable tissue levels for the full 90 days, totally independent of what is happening in the circulating blood plasma.
That is so elegantly simple, yet so effective. But this brings us to the core mission of this deep dive, the absolute center of the target.
Right, the troubleshooting.
Yeah. We've established how it's engineered to work, a 90-day self-regulating slow drip system. But what happens when a patient is a month into this therapy? The ring is doing its diffusion thing, but they are still experiencing baseline dryness and painful friction.
Because the clinical guidelines are very clear that this happens frequently, some people simply need a more aggressive, localized approach.
And this presents a really unique clinical challenge. The British Society of Sexual Medicine, alongside other international guidelines, states clearly that if a patient isn't responding fully to their initial localized treatment, the dose and frequency need to be adjusted.
But the S-string introduces a paradox here.
Right. Here's where it gets really interesting for you listeners. If you're prescribed a localized estrogen cream or a small vaginal tablet like Vegifem, and you're still dry, the adjustment is incredibly straightforward. The guidelines just say, use it more frequently.
Right, bump it up.
Yeah, if twice a week isn't cutting it, bump it up to every other day. You control the frequency, but you cannot exactly wear a continuous 90-day ring faster.
Exactly. You can't speed up Fick's law.
So what are the specific medical guidelines for adjusting the dose? Do you just pull the ring out at day 60 and put a fresh one in early to get another one of those initial absorption spikes?
Absolutely not, and that is a common misconception. Replacing a ring early does not give you a sustained higher dose. It just needlessly resets the 90-day clock and wastes medication. Conversely, leaving it in longer than 90 days is also a mistake. Once the 90 days are up, the reservoir is depleted. Leaving an empty ring in place causes underdosage, which opens the door for a rapid return of atrophy, inflammation, and infections.
So if you can't change the ring schedule, what is the actual protocol?
The medical guideline for adjusting treatment when utilizing a continuous device like the A-string is a strategy called layering.
Layering. Okay,
Yeah.
so we're essentially doing a multi-step routine.
Yes, you are combining therapies to treat different anatomical zones simultaneously. You leave the 90-day ring in place internally, let it do its job on the upper vaginal vault, rehabilitating the internal tissue and supporting the urinary tract, but you layer an additional treatment on top of it.
Specifically targeting the external anatomy, right?
Yes. The guidelines recommend combining the internal ring with an external application of an estriol cream, such as Ovastin 0.1% or 0.01%.
That makes a lot of physiological sense. The S-string is sitting high up in the vaginal vault. But a lot of the pain from GSM, the friction from walking, the pain during intimacy, the general daily soreness, that all happens externally, right? Now, the vulva, the labia, and the actual entrance to the vagina.
Precisely. And that external vulvar tissue is biologically slightly different than the internal mucous membrane. It often requires direct topical application.
Right.
So the patient allows the S-string to handle the internal environment while manually applying the estriol cream directly to the external areas experiencing the most friction and distress.
But the layering doesn't stop at hormones, does it? The sources heavily emphasize layering non-hormonal products as well.
Yes. This is a critical and often overlooked pillar of the clinical guidelines. They recommend regularly layering non-hormonal vaginal moisturizers. Products like Yes's VM or Silk are frequently cited at least twice a week, and they explicitly stress that these should be used regularly, entirely independent of sexual activity.
Okay, but I have to play devil's advocate here on behalf of the patient. Go ahead. The whole appeal of the S-string is convenience. It's a set-it-and-forget-it device. You put it in 4 times a year. If I'm a patient who is still suffering, and you tell me that the solution is to leave the ring in, but now I also have to apply a hormone cream externally, and I have to remember to use a non-hormonal moisturizer multiple times a week.
It sounds like a lot.
It sounds incredibly annoying. It turns a low-maintenance device into a highly active, multi-step chore.
Your frustration is entirely valid, and it's a reality many patients face. It is a chore. But from a clinical perspective, we have to look at how these different elements perform completely different biomechanical tasks.
Oh, explain that.
The hormones, so the ring and the cream, are signaling the cells to rebuild, but that rebuilding takes time. The moisturizers provide immediate structural support to the tissue while that rebuilding is happening.
And we should clarify, a moisturizer is very different from a standard personal lubricant.
Oh, a massive difference. Lubricants are designed for temporary friction reduction during intimacy. They just sit on the surface. Moisturizers, on the other hand, actively change the fluid content of the epithelium.
How so?
They contain specialized polymers like hyaluronic acid or complex plant gums that are bioadhesive. They actually bind to the epithelial cells.
So they grab onto the cell wall and hold water there.
Exactly. They alter the local osmolality. They bind water molecules to the tissue and slowly release them over several days, deeply rehydrating the cell structure and mimicking the natural transudate the fluid that a healthy vagina produces.
Wow, that's really advanced.
Yeah. And furthermore, good moisturizers are pH matched, so they actively assist the estrogen in pulling that pH level back down into the acidic safe zone.
Right.
So it really is a multi-pronged therapeutic approach.
Mm.
The internal ring provides the baseline hormonal engine, the external cream targets localized soreness, and the moisturizers keep the tissue structurally hydrated and acidic.
So what's the ultimate backup plan? What does the guideline say if a patient diligently follows this entire layering protocol, the ring, the cream, the moisturizers, and they're still suffering from painful GSM symptoms?
If combining therapies fails to bring relief, the guideline is clear. You must return to your clinician for reassessment. The patient may require a systemically higher maintenance dose, a complete change in the type of localized formulation, or, crucially, further dermatological investigation.
Meaning something else entirely might be wrong.
Exactly. If hormones and intense moisturizing aren't fixing the tissue, the clinician needs to rule out other underlying conditions, such as lichen sclerosis, which is an autoimmune skin condition.
Oh, I've heard that.
Yeah, it can mimic the severe itching and structural changes of GSM, but requires strong topical steroids to treat, not estrogen.
Okay, so let's say the layering works perfectly. You finally have your symptoms under control. You get your estrogen prescription renewed. You go to the pharmacy. You open the little cardboard box, and out falls the patient information leaflet. And this is where the psychological aspect of this treatment goes completely off the rails.
Ah, yes. The infamous leaflet paradox.
It's wild. You unfold this massive paper insert, and it reads like a horror novel. It has giant warnings for endometrial cancer, deep vein thrombosis, blood clots, stroke, dementia.
I know.
It sternly warns you that if you still have your uterus, you must be taking a systemic progestogen to protect your uterine lining from cancer. It is literally the medical equivalent of buying a cup of decaf chamomile tea, but the mandatory warning label on the box warns you about the risks of drinking a dozen triple espressos and going into sudden cardiac arrest.
That is so true.
It's no wonder patients read this, panic, and throw a perfectly safe, highly engineered ring straight into the trash.
It is arguably one of the most significant sources of clinical frustration in menopause care today. To understand why this happens, we have to look at the history of medical regulatory bodies.
Right, the WHI study.
Yeah. In the early 2000s, the massive Women's Health Initiative study published highly publicized data highlighting systemic risks associated with traditional high-dose HRT, the pills that flood the whole body. In response, regulatory bodies like the FDA in the US and the MHRA in the UK panicked and applied class-wide black box warnings to virtually all estrogen products.
Regardless of the dose and regardless of how they are delivered, they treated the whole yard sprinkler and the slow drip irrigation line as if they were exactly the same thing.
Exactly. It's profound bureaucratic lag. If we connect this to the bigger picture, the clinical consensus today, the actual science, is crystal clear. The British Society of Sexual Medicine guidelines take a very firm stance on this.
What do they say?
They explicitly state that clinicians need to actively reassure women about the inaccuracy of the product leaflets included inside vaginal hormonal preparations.
I just want to underline that for you listening. The major medical societies are literally instructing doctors to tell their patients that the mandatory government-approved safety leaflets inside the box are medically inaccurate for this specific use case.
Because the biological reality simply does not match the warning label. As we discussed, the localized dose from the E string is so incredibly low that it does not persistently elevate estrogen levels in the systemic bloodstream.
Right.
Therefore, the guidelines clearly state that endometrial protection, taking an additional progestogen hormone to force a bleed and protect the uterine lining, is categorically not needed when using local low-dose vaginal estrogen. The systemic risks on that leaflet simply do not apply.
And this distinction between systemic risk and local safety is especially critical for one specific group of patients: breast cancer survivors. The sources spend a significant amount of time addressing this.
It is a profound quality of life issue for these women. Many patients who have survived estrogen receptor-positive breast cancers are prescribed medications called aromatase inhibitors.
And let's explain how those work, because it dictates why their GSM is so severe. Aromatase inhibitors don't just stop the ovaries, they block the enzyme in the body that converts other hormones into estrogen in peripheral tissues. They essentially nuke the body's backup estrogen supply, dropping systemic estrogen levels to literal zero.
Precisely. And the resulting sudden, profound onset of GSM symptoms can be agonizing. Historically, oncologists told these survivors that they could never, ever touch estrogen again in any form, under any circumstances.
But the clinical evidence is shifting that narrative, isn't it?
It is. While it always requires shared decision-making with their specific oncology team, the current guidelines note that it is considered reasonable and safe for many women with a history of estrogen receptor-positive breast cancer to utilize local vaginal estrogen like the estring.
That's huge.
It is. Rigorous studies have shown that it does not cause persistent elevations in serum estradiol levels, and crucially, it does not show an increased risk of cancer recurrence. For a survivor whose quality of life has been decimated by aromatase inhibitors, regaining daily comfort and sexual function without compromising their cancer care is absolutely life-changing.
Wow. And the final point we need to make about this treatment is its duration. Because it is highly effective, a lot of people get confused by the end game. They use the ring for a 90-day cycle, their tissues cornify, the pH drops, they feel fantastic, and they think, great, I'm completely cured. So they don't replace the ring.
And within about 3 weeks, the tissue atrophy and the symptoms begin to return.
Because localized estrogen isn't a cure, it's an ongoing, permanent support system.
You're replacing a cellular signal that the body has permanently stopped producing on its own. Think of it like wearing prescription glasses. You wouldn't wear glasses every day for a year, realize your vision is perfectly corrected while wearing them, and then throw them away expecting your eyes to stay fixed.
No, of course not.
The glasses only work while you use them. Similarly, you cannot expect the vaginal tissues to maintain their structural integrity once the localized estrogen is removed.
Which is why the 9C guidelines in the UK explicitly support using this local therapy for as long as it is needed to maintain symptom release and improve quality of life. There is no arbitrary cutoff date.
Yeah.
You don't, age out of needing healthy tissue.
Exactly.
So bringing all of this highly specific pharmacology and clinical strategy together for you, the listener, if you are dealing with the painful reality of genitourinary syndrome of menopause, the estring is a brilliantly engineered, slow-drip, 90-day solution that leverages Fick's law to stay beautifully localized. It rehabilitates the tissue without flooding your entire system.
And if you are using it but still feeling that baseline friction and dryness, remember the specific clinical protocol. You do not mess with the ring's 90-day timeline. You don't try to outsmart diffusion.
You layer, you treat the internal anatomy with the ring, you add an external estriol cream for the vulva, and you diligently apply non-hormonal bioadhesive moisturizers to keep the cellular structure physically hydrated.
And perhaps most importantly, you trust your clinician over the outdated class-wide warning leaflet in the box. Do not let bureaucratic lag and systemic warnings scare you away from a targeted, safe, long-term solution.
It really is a marvel of what localized medicine can achieve. We're delivering the exact required molecule exactly where it is needed in a microscopic dose that self-regulates for a quarter of a year.
Which leaves us with a fascinating thought experiment to consider. We've seen how incredibly successful this model is for the pelvic floor. A localized, continuous drip therapy that entirely bypasses the bloodstream and rehabilitates specific aging tissues without triggering systemic side effects.
That effectively stops local biological aging in its tracks.
So as medical technology continues to advance, and as we get better at bioengineering these self-regulating, slow-release polymers, could this exact model eventually replace whole-body systemic pills for other types of age-related tissue degeneration.
Oh, wow.
Imagine a future with localized 90-day microdosing implants for degrading joint cartilage or targeted vascular beds, rather than swallowing a systemic pill that floods your entire biological system to fix one localized issue.
Wow. Taking the localized slow drip approach to the rest of the aging body, moving completely away from the whole yard sprinkler, and revolutionizing how we age one specific tissue at a time. Something fascinating to think about.